Good morning, everyone. I am presenting the case of role of percent topical atropine and eye drop for slowing progression of myopia in pediatric age group. First is introduction. Myopia is the most common developmental eye disorder. Usually starts during primary school and progress till main age of 16 years. Around 2.5 billion people by 2020 and half of the world population by 2050 will become myopic. In India, its prevalence was 2.1% in children aged 5 to 15 years. Around 2.5 billion people uh, by 2020 and half the population by 2050 will become myopic. If myopia progression can be reduced, myopia will be less in adulthood and therefore risk of complication will be lower. Common methods for slowing progression of myopia includes bifocal and multifocal spectacles, ocular hypertensive drugs, orthokeratology contact lenses, anticholinergic eye drops such as atropine and pyrazine eye drops. To date, atropine is the most effective medication for slowing progression of myopia. Atropine is a non-selective muscarinic antagonist. Its exact mechanism of slowing myopia progression is still unknown, but may be due to its anti-cumulative property and by regulating muscarinic receptor retina, choroid, and sclera, which prevent axial elongation of eyeball. Aims and objectives are to determine change in refractive error after administration of 0.01% drop in eye drop for 1 year, and to assess the change in axial length of eyeball using a scan, and to determine safety of 0.01% drop in eye drop by assessing its side effect. Material methods. Inclusion criteria are pediatric patient age group of 6 to 18 years and myopia progression which is equal or more than 0.5 diopter per year, and children having simple myopia in at least one eye, and if astigmatism is present in either eye it should be equal to or less than -2 diopter. History of ocular trauma, surgery, keratoconus, corneal scarring, cataract, posterior staphyloma, coloboma, optic atrophy, pathological myopia, and allergic to atropine, amblyopia, retinal disease such as retinitis pigmentosa, and trauma to retina are excluded. First come result and observation. This chart shows that uh, approximately 54% children are male and 46% are female, and uh, in 7 to and 7 and 18-year age group there was no children, and most of the children are in 13 year and 17 years age group. This graph shows that pre-treatment mean axial length was 24.15 mm, and after 1 year of treatment it becomes 24.35 mm. So zero point 0.2 mm mean axial length change what occurred, and in starting mean spherical equivalent was 2.37 diopter, and after 1 year of treatment it was 2.78 diopter. So 0.41 diopter increment occurred in refraction, while we included children which has equal or more than 0.5 diopter per year change in effective error. This graph shows distribution of study subjects according to myopia progression rate. This shows that approximately 50% children shows myopia progression less than 0.5 diopter per year. This chart shows that as age increases, change in myopia progression was decreased. Distribution of study subjects according to adverse effect. In 3% children, transient photophobia and transient headache was seen, which was resolved after 1 minute, after 1 month. Discussion. For myopia, both genetic and environmental factors are responsible, but in recent time, increase in myopia cases appear because of environmental factors such as more time for near work and less time for outdoor activity. In our study, mean myopia progression of 0.41 diopter was observed, which was similar to 0.3 diopter progression in Jitendra Thaini study and 0.43 diopter in attempt 2 study. In our study, 0.20 mm of axial length change was observed, which was similar to 0.24 mm of attempt 2 study and 0.36 mm of lamp study. Transient photophobia in 3.84% and temporary mild headache in 3.84% children was observed, which was supported by Matthew Sachi et al. Study and G. Larkin et al. Study. Atropine effect does not depend on gender. Supported by study conducted by Mihir Kothari et al. Our study limitations are short follow-up period, hospital-based study, so may not be represent the real picture at community level. Rebound phenomena after stopping the eye drop was not evaluated. Very few studies have been done till now, so further evaluation is required. Conclusion: 0.01% drop in eye drop may not be effective in each individual. And effect of 0.01% drop in eye drop does not depend on gender. To reduce the rate of myoprogression, atropine 0.01% atropine is significantly effective with minimal side effect. Thank you.
How did you measure the axial length?
By A scan ultrasonography, three
Con-
readings
Which
were
A
taken.
scan? Which A scan?
Contact or motion?
Contact.
So was it done by one person?
Yes, ma'am.
Like was the user, like whoever was doing the A scan, was the standardized person doing it, or
I'm a resident. I think.
all different residents?
Yes, ma'am.
And why did you choose the age group 6 onwards, 6 years onwards?
Before 6 year, when during birth, children was hypermetropic, and up to 5 to 6 year, process of metroparism generally completed. So after 6 years, children was included. In most of the study, they included children of 6 to 12 year, but we included children of 6 to 18 year because in some studies it has been seen that after 12 years, rate of myoprogression is still continued.
Did you have a control group?
No, ma'am.
So then how can you compare the axial lengths? How did you?
Axial length cannot be compared, but spherical equivalent was compared.